Hello and good morning to everybody. Welcome to day 4 and the last virtual day of the 2023 BC Digital Health Forum, inspired by Digital Health Canada. Starting off with that by Canada Health InfoWays Digital Health Week. You can tell I've been talking a lot this week already. We're so excited to be back with you again today to enjoy some fantastic presentations, highlighting once again the incredible digital health revolution taking place in BC. Want to highlight, lastly, or get a chance to highlight that it's brought to you by an organizing committee, including many teams across PHSA and the wider healthcare system in BC. You may know this already, but my name is Tina Costa. I'm one of the directors with PHSA's Office of Virtual Health, and I have the honor of being your host once again for our virtual sessions today. As always, I want us to take a moment to meaningfully ground our day. I would like to invite everyone gathered today through our virtual circle to take a moment to acknowledge with gratitude that we are joining together across many traditional, ancestral, and unceded territories of BC First Nations. May we all take pause to honor their connection to the land, their stewardship in caring for and nurturing these lands for all time. I myself am a white settler and an uninvited guest on these lands, and I'm joining today from the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations, colonially known as Vancouver. As we continue our conversations about digital health advancements and innovations, let us carry forward the importance of recognizing the traditional custodians of the land. Just a couple of key reminders I'll get into quickly. We're pretty used to how things are going now, but we want to just highlight continuing to have our accessibility features available so everyone can fully participate. Reminders for folks online to send presenters your questions using the Q&A icon on the main window. There are still prizes to be won, so check those out on Feedloop Go app. All presentations will be recorded and available following the event. And lastly, there is still room to join the Healthcare Design Thinking Workshop tomorrow. If you haven't signed up, you can make sure to do so, but do so before 5 p.m. today. And if you do need support throughout the day, make sure to just reach out in the chat and our incredible team in the back end will help connect you. Without further ado, want to get day 4 started and excited to be here with one of BC's well-known and esteemed digital health leaders. I have the absolute pleasure of introducing our first presenter today, Dr. Kendall Ho. Dr. Ho is an emergency medicine specialist, a professor in the UBC Faculty of Medicine, and leads the Digital Emergency Medical Unit. He's the medical director of the BC Ministry of Health 811 Virtual Physician Program. Dr. Ho's digital health research focuses on equity of access to high quality urgent care services via virtual care, sensors and artificial intelligence in emergency department triage and patient monitoring, and also raising digital health literacy of patients and health professionals. Please join me in welcoming Dr. Ho for his talk on a community-based real-time virtual support for patients with health emergencies. Dr. Ho.
Wow, Tina, thank you so much for that very, very kind introduction. It's my distinct pleasure to be able to be here. And again, thanks for all the participants being here. I look forward to not only, give a little bit of the information, but I look forward to learning from you and understanding from you the questions that you may have, and also your thoughts and advice as we move forward. Really, it's a pleasure to be at this BC Digital Health Forum. I'd like to first acknowledge that I'm calling in from the traditional, unceded, and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. This is where I live, and as an invited settler in Vancouver, and I feel very, very fortunate to be here. And very glad that I'll be able to spend maybe now a minute with you on the topic of the 811, the area where I've been had the wonderful opportunity to participate, being invited by Sandra Sandhu, the Executive Director of 811, and the Ministry of Health, to participate in this virtual physician program, to join with our nurses and our pharmacists in this virtual care team in delivering health services. And so I'll be doing that introduction itself. I'd like to first do a disclosure Of course, because of my work, the Ministry of Health has provided a grant to our UBC Faculty of Medicine, and through which I get to do the work that I do, and also collaboration, and also through the JSC funding with the Rural Coordination Center of British Columbia. And I do have, I will be touching on some of the work that I do with National Research Council, some of the grants we have the CIHR, and Canada Health Infoway and Patient Engagement, Healthcare Excellence Canada on patient engagements. And I do receive funding from foundations, private donors. And I sit on 3 unpaid boards as displayed there. Finally, if I have certain bias I haven't declared, and if you have any questions, I welcome you asking me questions about conflict of interest, and also make sure that I'm not blinded to the conflict of interest that I'm not aware of, but you will bring that perspective to me. What I'd like to do in the next 18 minutes is to approach it in these 3 ways. First, looking at health emergencies in our communities. What are some of the issues, and what are some of the ways that the gaps that we need to fill? And then really focus on the 811 in terms of types of things we try to do to fulfill some of the gaps. And we also need to learn how to continue to do better. And so the last section is really about how do we create a learning health system for us to continue to improve. Life is always unexpected. We can plan as best we can, but health emergencies or urgencies is just like life itself. You can't predict. You know, new mother with their 3-month-old, the first time with fever and vomited twice. Always happen on Friday night. You can't get hold of your family doctor if we're lucky enough to have a family doctor. Or a person wakes up at 3 a.m. in the morning, suddenly onset for the first time with chest pain. Lasts about half an hour, and then the pain's gone. In both of those situations, they'll be asking themselves, wow, is this serious? You know, can I last the nights till the morning before I get the type of help that I can get? Or is this something I need to go to emergency about? Or this is something that I don't really need to pay more attention to. When we look at the health system, again, the big picture is that there is a crisis going on in emergency departments, not in any particular group's making, but it's just with the perfect storm, it happens to the point that we have overcrowding in emergency departments, occupation of the beds in emergency that we cannot admit to hospital or send from the hospital, send back to the community, and also a long wait list in the waiting rooms. You know, stories about waiting in the emergency department for 4 hours, 6 hours, 10 hours, 14 hours before you get to see a doctor. Also stories across Canada about people dying in the emergency department because they're not observed. That caused a lot of anxiety and also hesitation for our patients, and our health professionals are trying our best to be able to support that. And so under these type of circumstances, what can we do to improve for the patients a health need that happens unexpectedly, and also supporting a health system that we can make things transition smoother to hopefully that future state where we solve these crises and move forward with a strong system. HealthLink BC has historically been established in 2001. And in fact, we have a very good, very competent group of nurses who've been handling calls in case people have health issues, not emergencies like 911, I need an ambulance, I need to go to hospital because of crushing chest pain, but for those emergencies where a person says, I don't know whether I need to go or not to emergency, or where should I seek care, that our nurses have been tremendous in providing that support. But when COVID hit in March 2020, there's a significant transformation. That one, that people need to be in social isolation. Two, a lot of hesitancy of people wanting to go to emergency department or actually go into the office because of not only social isolation, but also because of the virus itself. You know, will we catch the virus ourselves? And three, it also challenges our health system delivery. And four, it's a new disease. It's not a traditional disease, but it's entirely new. And so at that point, I was involved with Rural Coordination Center, BC, First Nations Health Authority, Ministry of Health, setting up the real-time virtual support network for the province, looking at virtual care delivery for peer-to-peer between health professionals and also patient-directed care. And very fortunate to be invited by Sandra to join 811. And so at that particular point, we want to figure out how do we form this virtual care team to support our patients in what their needs are. And so on the right column of this slide, we have 4 key goals of setting up this service called HealthLink BC Emergency Eye Doctors in Assistance, or HIDE. Number 1 is we want to make sure that we support and address the patient's factual needs, but also reduce the anxiety at the same time. Secondly, we'd like to try our best to preserve the acute care capacity. For those who don't need to go to emergency, that we will be able to provide them with advice so that they don't need to go. Now, of course, when we look at the emergency crisis, a lot of people say, well, when we look at the emergency population, 7 out of 10 patients don't need to be in emergency for their services. When you look at it from a health system point of view, we need to understand that these are after these patients were seen and assessed by physicians and nurses and health professionals, and then determine retrospectively that they don't need to be there. But imagine in that situation, that mother or that person with chest pain, it's very hard for them to tell whether they need to be in hospital or not. And so this is the point that we want to do, that we put that advice right up front to support them in their decision-making process. The third is, it's not just about needing to go to emergency or not, but to advise, are there ways that we can use the health system to address the issues that you have? Sometimes the health system is like me going into a completely new city in the world. I have no idea. I need a guide. And so we're hoping that 811 will be that guide to support the patient to navigate our health system. And then finally, if the patient have family doctors, we want to be able to refer the information back to a family doctor to maintain that longitudinal care. And if they don't, that 811 is emerging to work with Doctors of BC and work with different organizations to start identifying attachment opportunities for them. So those are our 4 key goals, and we continue to be looking at those goals. Since April 6, 2020, that's when we first started. We took 3 weeks to organize until this graph, slide on October 8th of 2023. We've seen now 190,000 cases of patients through this virtual care team of nurses and physicians working together. And with that, we start off, of course, the patients start off with 811, dialing in. And when the nurse felt that they need to see a doctor, for cases that the nurse feel, oh, you can stay home or you can address it this way, physicians are not engaged. But for those that if nurses feel, okay, it's this patient need to see a physician and need to see them fairly urgently within 1 to 4 hours of the window, that they will be referred to us as virtual physicians. And we'll pick up to call the patient back and through telephone. And then if necessary, we'll switch on the video. And about 20% of the time, video is indispensable in providing our service. Hey, doctor, I cut my face and it stopped bleeding now. And I really don't want to go to emergency department. Do I need to go and get it stitched? Now, you can get a patient to describe it 10 different ways on a phone. It's never as direct as turning on a video and say, can I take a look at your wound? And so that's an example of video really making a difference. We're very glad that patient satisfaction, for those who voluntarily answer back, we had good satisfaction, and we will be looking at more representativeness in how we can continue to improve our service. On the top right, you can see the graph of distribution of age and sex. In this case, it's not gender, it's sex, in terms of people coming to our service. You can see that the 20 to 65 are the 2 most popular groups that are accessing our service. But of course, in the older population and also in the younger population where the parents call in, you can see the distribution of that number. The bottom table is when, do note that when nurse sent them over, they felt that these patients would need to see a physician. Before the virtual physician service, these patients would have been referred to emergency department or urgent care center. But I'd like you to focus on this column of percentages. You'll see the actual number on the other column. We were able to actually, in the last 3 rows, divert 7 out of 10 patients away from emergency with the service. The nurse would have fulfilled their mandate to have the patient connect with a physician. And we then support our patients through excellent nursing notes and then talking with the patient to identify that, in fact, 7 out of 10 don't necessarily need to go to emergency. But 21%, we say, you got to go. Your chest pain sounds very much like a heart attack chest pain. We have a rural patient about 4 weeks ago where they called in and said, yeah, I injured my chest, feels like rib pain, what should I do? But on further discussion, that injury was 2.5 months ago, and the person didn't have any more chest pain until the week when the person called. And I found out that during that week, they were having more frequent chest pain with exercise. So that pattern is very different. And so despite the fact that it's 45 minutes away in the merge, I said, you got to go. And for those who are trying home treatment, 37%, close to 4 out of 10, they don't necessarily need to interface with the health system anymore after the call. Of course, we'll say, if these things happen, you then need to see a doctor. Otherwise, you can stay home and see how you do, and then go from there. And then about 1/3 of them will suggest you need to go to see your family doctor, not urgent. You can go see them in the next 7 days to 14 days. And so with that service, we were able to produce our first paper and published in 2021 to start describing the service. And for those who are interested, happy to share that reference with you. We're very interested to ask this question. After we've given the advice, would patients actually continue to support what we advise them, or jointly say this is the right direction? So what we call concordance. What our advice, would the patient have concordant behavior associated with that advice? And so we look at a time period where we look at the 24-hour emergency department follow-up if we advise them to go to emerge, and 7-day advice follow-up to family doctors, what that looked like. And so we, with this period, we picked out close to 6,000 patients. And then 14% is from rural locations calling in, which is roughly the distribution number that we have. And we found that, for example, in the red category, there's actually 1,500 patients that we advise to go to emergency, for example. And several interesting findings that we have. Number one is that we find that when we advise them to go to emergency, that 63% would actually end up going to emergency department and register with a fee code associated with them visiting emergency department. For those that we advise go see a family doctors, within 7 days, there's a MSP billing code that's associated with about 46% of them going to see their family doctors. Now you can say, well, those numbers doesn't look that impressive. In fact, we'd love to be able to continue to improve it, but that's how it's going to help us to understand what did we not do that may not be helpful to our patient. Or very often we got the call, I'd like to go to emerge, but it's like a 12-hour wait. I don't want to go. Or, when I call my family doctor, sometimes it takes up to 2 weeks, 3 weeks before I can get an appointment. Also, it's very important for us to understand that how do we continue to change our service and also change our partnership so that in the future, we would want to use these numbers to help us to increase the concordance and to understand how do we adjust in our activities. So I'll come back to that on the learning health system. We do know that within this cohort of patients, 8 persons died, but 5 of them were referred to go to emergency department immediately, and 3 of them were palliative care. And finally, very fortunately, we look at those patients that we said stay home. This is a very important statistic for us. Nobody died when we asked them to stay home. That's vitally important for us. And so if you're interested, again, we published those findings into a 2023 paper, and you're very welcome to access that. Since then, we've evolved 2 other additional services. One is about the prescribing of Paxlovid for those who has COVID and are at risk of increased hospitalization. And so for those patients, we were able to, initially when it first came out in January 2022, that there's a limited supply, but then Paxlovid supply become very accessible from a prescription point of view. And so what we did is throughout the province, we try to figure out how to help our patients get that prescription when they are necessary. And so over time, we partner with our doctors, specialists, and pharmacists to evolve that system. And so as of the April statistics, we have seen over 10,000 patients. About 47% of them receive a Paxlovid prescription because they're eligible. And then we're able to refer 3% of them to a hospital for IV because the Paxlovid is not appropriate. Interesting on that curve on the bottom left, you can see the waves that it comes. And in fact, when we start detecting an elevated phone calls, the next day, we start to understand that there's a trend, that there's a wave coming. And so we're going to continue to exploit this type of data to help us to understand how does that correlate with waves of COVID coming. Another issue that we tackled this year in January, we start a line called Provincial Prescription Renewal Support Service. Patients who don't have family doctors, sometimes it's tough for them to try to get a prescription. They're not sick, but if they don't get their medications, they will get sick. But because there's no family doctor, they couldn't get a prescription through the routine way. And so they have to go and walk-in clinic or urgent care centers. In those communities where there's no urgent care centers, perhaps the only way to get it is through the emergency department. I'm very glad that community pharmacists are helping to prescribe prescriptions, but sometimes if the prescription is expired, or the patient or the physician has retired, that sometimes there could be logistical issues, or the pharmacist may have clinical issues to want to figure out how to support patients with prescriptions. And so rather than having these patients needing to go to emergency departments, knowing that they know that they're not welcome there, and the emergency department personnel know that they need help, and yet because of overcrowding, that these patients often are not the priority, how can we get the situation better? And that's why we set up this line. Again, really want to thank HLBC, want to thank our pharmacists, our nurses working together with our clinical administrative folks, called the health connector, patient connectors, to help us to connect with our patients. And so we've been doing this prescription renewal for those patients when the pharmacists want to refer us to their patients. And so again, statistics here is till May, and we're able to fulfill 65% of those prescriptions. Otherwise, they would have gone to urgent care center or emergency departments. And also for those that are things that need assessment, we were able to refer them to emergency or walk-in clinics or urgent care centers. All right, my final section is about the learning health system. I'll wrap up in 3 minutes. I know my time is running out. And so the question is, how do we introduce innovations to a health system? In COVID, we had to do it very rapidly. How do we dawn on, dawn off? How do we do isolations? In intubation, how do we learn to intubate so the health professional is not at risk? How do we do virtual care, which is one of the areas that we do that? The question then is, how does a learning system, how does a health system learn? We need evidence like papers, we need change management, we need some process. But we have adopted the system of using a learning health system, and that is through internal data, guided by external evidence. How do a group of us implement that into practice? So this is a paper by the person who actually is the father of learning health system, Chuck Friedman. And he talked about these 3 aspects of a learning health system. The bottom right is a group of people who want to change the system, the forming of a learning community. And very fortunate, we have governments, we have health professionals, organizations, patients, all of us want to learn at the same time. The top left is we need external evidence. What are some of the external evidence to show that virtual care help, for example? But the center is where the magic happens. The K to P is from, we start with the D to K, the data of what the gaps are, the needs are, and then from there, with the external evidence, what type of knowledge do we need to introduce in the system? And then with that knowledge, how do we go K to P, embed that knowledge into practice, such as how we set up our 811 line, how do we get the calls, how do we use videos, etc. And then from practice, we generate data, such as the papers that we've published to date, and understand 65% of people would have concordance go to emergency. And then we go back to data to knowledge. How can we increase that concordance so that we can improve the service? That's the core of what we're trying to do. And so we start looking at the concordance as the first example to do as one of the example of doing this loop of learning health system. And we do analysis such as this diagram so that we understand when nurses refer to physicians, what are some of the categories of patients that are referred to us, and how do we translate those categories that help us to understand the flow of the patients. We've also set up a provincial dashboard so that we can keep track of all the data as we evolve to learn from it. And so, ladies and gentlemen, I'm going to conclude. I apologize for going a little bit late. And Tina, my apologies for handing this back to you. At the end of the day, our mission is to how do we support patients at their time of need, that we can help them make decisions. We can help our health system to support the use, the rational use of our health system. So we maximize the benefits to our patients and also maximize value for money. And how do we then create really this support the province as part of a digital front door so that through Emerge, through staying at home or going to hospital, that we can provide the best service for our patients. Thank you very much for your attention. I appreciate that a lot.
Dr. Ho, thank you so much for starting day 4 off with such a fantastic presentation. Really a great perspective on how virtual care service, particularly that first contact virtual or digital care service model, can support patients not only in the moment, but also the health system downstream. So a great example of these innovations. We do have a couple of questions, and I think we've got time for a couple. So the first one is maybe a provider out there or healthcare professional wondering about where the care is documented when you're seeing them, and is it available on Care Connect?
Yeah, at this point, we are documenting through Care Connect. So once we've seen the patients, that will be uploaded to Care Connect. So when they go to their family doctors, when they go to emergency department, when they go to urgent primary care center, the health professionals there can pull the information down from Care Connect. What we hope to do is the next step is to work with our emergency department, work with our health authorities, work with our urgent primary care centers and doctors of BC, so we can push the contents into their electronic record. So when they pull up the patient's record, right away it's there. So that will be our next step where we want to go in the future.
Fantastic. This is a question that a few people have voted for. I'm curious myself, what has been the biggest learning for you in setting up a service like this?
Oh, wow. Maybe I'll talk about the most impactful learning that we have, and is that the patient welcome us into their homes, into their most vulnerable moments, and we're able to help them as a friend. I think that's the best thing I learned. You know, in the emergency department, they have to come to me to get the services, but with virtual, we can start at their home. But virtual is not enough. It's not about virtual versus in person. It's about virtual and in person together, support our patient. To be able to start that journey with the patient in their homes, invited to their most vulnerable moment and support them, is one of the biggest learning. And how do we continue to make sure that that happens is going to be vitally important for us.
Phenomenal. Thank you so much, Dr. Ho. It's been a great morning with you to start off the day. We will close this session now to keep us on time. And so please, those of you, I know there were a couple questions there that you might not have got answered specifically. So please reach out to Dr. Ho to learn a little bit more, particularly a couple questions just around some of the data that you shared, Dr. Ho. So thank you again. We will, as I mentioned, end this session. You'll online see a Zoom poll to get a bit of feedback pop up here shortly. There it is. Love how it always magically appears for me. And as we wrap up, we're going to invite you to our next session of the morning, which is entitled Teaching by Texting to Promote Healthy Behaviors in Pregnancy. Gentle reminder again that you can navigate to that on the left-hand side of your panel on your screens. We will see you all there shortly. Again, Dr. Ho, thank you so much.
Thank you very much, everyone. Pleasure. Bye-bye.